Welcome to The Lead Climb, the podcast where we break down the strategies that drive patient acquisition and growth in behavioral health. Hosted by Growth Sherpa Consulting, we bring you expert insights on digital marketing, admissions, business development, and more, so your treatment center, mental health clinic, or private practice can thrive. Whether you're a CEO, admissions director, or marketing pro, this is where you'll find the tools to scale smarter. Follow us up the mountain. Let's lock in. Welcome to the Lead Climb podcast. This episode, we have Tony Porter with Blue Star 360. Tony, why don't you introduce yourself to everyone?
Thanks, Steve. Appreciate it. Glad to be here. So I've been in healthcare probably about 20 years. Started off in med-surg, post-acute care, moved into behavioral health about 17 years ago. I worked for the largest behavioral health company in the country. I started off at one of the largest facility that they had, and then as the director of business development, one of the administrators there, and then moved up to corporate business development. And then when I left that company in 2023, I was a senior divisional director overseeing approximately 70 hospitals through some direct and then through other folks that work for me, divisional directors, divisional managers, regional managers. So I've worked on both the business development side and the corporate development side, working more closely with corporate development over the past several years prior to leaving, and looking at new markets, looking at new programs, looking at new services, looking at de novos, joint ventures, and bringing market intelligence, competitive intelligence, and really a lot of feet on the street, business development, word of mouth knowledge back to the corporate level and translating that so where we could make strategic decisions about where we were going to move next. So when I left, I had the opportunity to come work with Blue Star 360, and it just kind of started off as a due diligence support until I, found my next gig. And almost 3 years later, I am still in that position doing mergers and acquisitions, advising, buy and sell side advising, consulting from a whole range of projects and services. Much like Growth Sherpa does, we look at everything from the front door to the back door, and even before the front door, and even beyond the back door. But primarily my role has been lately doing a lot of hand holding with people who are ready to sell their business, and then doing a lot of searching for people who are looking to buy a business. So that's where I am today.
Excellent. Yeah, and the selling the business is something that I was a lot more introduced to over the last few years versus my first, I don't know, 7, 8 years in the field.
Mhm.
What I think I didn't realize is how emotionally tied in a owner can be. Like, I think consciously, like someone's built up a program, a business, a team of people they like and care for, a facility that they have spent 40, 50, 60 plus hours a week at for a number of years.
Mhm. Mhm.
I think what hit me early was this isn't just a transaction. This is a deep relationship. This is I wouldn't say marriage because this, it's not the same, but it's definitely an emotional process. So, have you seen that more or less now that you've kind of gone away from the hospital system into this more diverse landscape? And I guess what else do you see from the buy sell side that a lot of people wouldn't recognize as something that's, probably more common than not?
Um, 100% agree. Yes, it's a very emotional sell. Most treatment centers, both mental health and substance use, or whatever you add anything in front of that word treatment, usually start from a place of passion. It's a passion project. A founder may have a personal experience in long-term recovery, their own struggles, a mental health issue, a substance use issue. They may have lost someone to suicide. They may have lost someone to an overdose. They may have had a family member or a child who had experienced long-term mental health or substance use, and they feel like we want to give back. We want to keep other people from having to go down the same road that we've gone through. So it does start off as a passion project. And a lot of the larger companies today started just that way, in one way or another. And so you're right. It's not a marriage. It's more like, and I liken this because it's very recent, almost a year. It's like giving your daughter away in marriage, and seeing your child get married. It's you've raised this child, and all of a sudden, they're going to be part of somebody else's household, and you want them to be taken care of and protected and nurtured the same way you took care of, nurtured, and grew, um, them while they were in your home. So founders that have started projects and started programs, have a very passionate attachment to this. One thing that is a sticking point sometimes with that is that they become the key person. They become the key person that, oh, well, we go to the founder. Oh, for that, we go to the founder. And they're so linked into the organization that sometimes they don't hire the right people around them, or they become removed and they hire a group of great people and they still see the day to day. But when it comes time to make a sale or even contemplate a sale, there's a less of a key person risk at that point. So they can pull away, the management team stays in place, the buyer is happy and the seller is happy. And that's just an overview. But there's a lot of steps prior to, during, and much after that that we walk through with founders. But there is a emotional attachment. You're exactly correct.
No, it's funny you say like giving your daughter away for marriage. I know you just recently did that, and congrats, that's awesome.
Thank you. Thank
My
you.
9-year-old just had her first boyfriend for 3 days, and that's why I can't have a treatment center, and I would never be able to get rid of it. That was not an emotion I was ready for at 9. It was a tough one.
I know.
But yeah, you bring up some interesting points. I'm a big systems guy, just conceptually. Like I truly do believe culture does trump systems for sure.
Very much.
Having the right people in, winning the talent arms race in your community, making sure you have the best folks and the best culture and supportive. That all matters. But from the scalability of a program, and for me, when I was reading deal decks. The desirability was always in what are the systems that are in place? What am I going to have to fix or build, right? How much labor is it going to take me to come in here and say, okay, we have no way of tracking calls, are understaffed. It's the one point of leadership is going to be leaving a post transaction. So now how do you keep your staff? Because you don't want inevitably 20, 30, 40%
Mhm.
turnover because key individual leaves. I think and we see that a lot, right? So I think that's always been like what I look at these in these deals is how did the treatment center build itself up as an entity, not as an awesome person who ran, something that they were very passionate about. I think it's a mix of the both.
It is. It is. And there's so much technology out there today. There's so many varieties of EHRs. Some people still use paper, believe it or not. Some people still use systems that were written uh, in the 1970s on green and black screens. But they are able to run the program. And so that's something you have to take into account as you want to grow. If you don't, even if you don't want to sell, you want to acquire, or you want to expand your footprint, expand programming. That's something that a founder and a leadership team really need to take seriously about what are the next steps. How is this piece going to fit into the puzzle? And what I have found, not just in healthcare, but prior to my healthcare career, I was in manufacturing and logistics. But prior to that, you know, good technology, great technology does not fix bad processes. You sometimes work in an organization, and I think most people that are listening to this can agree that you have a lot of people that have been there for a while, they know where the workarounds are. Well, when the workaround decides to leave or retire, then you're held hostage by their knowledge and you don't know how it was worked around. So I think when people say trust the process, but first you have to build the process. And from point A to point B, there's usually a very logical line. It may not always be straight, but there is a very logical line. But there's always room for the exceptions, especially when we're dealing with substance use and mental health issues, because we have to make exceptions in certain cases, but we stay as close to that roadmap as possible.
So then with that said, what I see a lot, and I'm sure you're in the same boat, you have a passionate leader, someone who started up a program who has maybe duct tape and bubble gummed it for a while, or has had the workarounds or had some
Mhm.
way of getting from point A to point B. And that's really a triage issue, right? Like you have to do what you have to do to stay in business today,
Mhm.
but you also need to keep an eye down the road. I tell people all the time, I hope and my goal is so that you don't have the same headaches next year as you have now. You have better headaches.
Right.
And the process is always getting better headaches. And when I work with folks, I ask, did you have the same headache a year ago? Yes. Well, that is something we need to correct. But the triage does come in place at some point where you do have to pivot from being someone who is just doing what you got to do to take care of the patients in house.
Mhm.
How do we put together a process-driven organization that is functional and that is scalable? What are your thoughts on? I mean, you've seen it all from the massive hospital systems. I don't think it's necessarily a size or a tenure in the market. I don't think there's any sort of like that sort of metric. But is there a cultural or behavioral time when you've noticed, and perhaps it's even more so now on your time at Blue Star versus at your time before, where a company should have a real sobering thought of let's sit down and get our boats all rowing in the right direction, all of our rowers in the right direction, and get this stuff fixed.
Well, I take a page from, the recovery process. You actually have to get your own stuff dealt with first before you can deal with somebody else's. Very true.
Mhm.
And I think it's not a size issue, although that does play into the dynamic. But it's a culture issue, it's a systems issue. It's like, what's the best way we can to take this patients? People first starting off, they're taking every phone call, they're taking every patient. They want to help, they want to help, they want to help. Others start off, it's like, yes, we do want to do all that, but we want to do it right so that we're not going back and refixing everything. And even in large systems, you sometimes have to go back and refix stuff because it wasn't dealt with correctly in the first place. The same is true across any size company. And one of the things that I do when working with clients, especially if they're getting ready to sell, is look at, okay, do I have access to this, and this? Just simple data, just simple KPIs. And I'm not talking vanity KPIs. I'm talking real metrics that they can actually look at and say, we know how many calls are coming in. We know where they're coming from. We know how many admissions we're getting each month. We know what our length of stay is. And I'll be honest, I have talked to some organizations that are like, well, we don't really track that. We just track admissions and money. Well, can you break down your revenue by, is it inpatient, partial, IOP, outpatient? Well, no, it's just all lumped into revenue. I'm like, okay, but there are ways around that. They may not be
Mhm.
tracking it up front. And I'd say, well, there's a way around that. And we're going to get to that. And I'm going to show you how to do it. And let's put that on the top of the list of these are things that we need to recognize as we move forward and are very upfront with a potential buyer when we're doing more of the due diligence stuff. We're very upfront and say, these are the systems they have in place. These are the systems that they need to have in place. Now, if we're selling to another treatment center, it's like, yeah, we can fix that along the way and do integration. If they're selling to a larger platform, maybe, or even a PE group, they're not worried about that because they're going to roll everything up under, their system and how they run things. But those headaches that you mentioned, I think it's a very good way of putting it. They're different headaches. The headaches never go away. But you're finding the right treatment, you're finding the right medication, it's like, all right, removing certain stressors, even though other stressors are coming on back on board. So you're helping the founders and the leadership team who, by their own right, are very intelligent people because they're running a company. All right, that right there says to me, they know what they're doing.
Absolutely.
But
Absolutely.
sometimes, I know what I'm doing in certain things, but sometimes I need to call you and say, all right, what am I missing? I need another set of eyes to look at it. And I tell future clients, and I had a call this week with a potential client, and just kind of we had a conversation about their goals and objectives, how they got started. Given my history, we had this conversation, and I said, "Well, you have to talk among yourself and decide what you want to do. I'm a phone call away. I'm not going to push you or pressure you. This is a huge decision you have to make, and you can either use me, or I can recommend you to someone else. But I want to help you." So I also tell them that at first you're going to love me because I'm going to, give you a list and say, this is all the things you've got to get done. And it's like, we're going to walk you through and we're going to handhold you. And we do handhold. And because it's so important that we handhold. But then probably the second week, you're going to hate me because I'm going to start asking you for everything. And I'm going to bug you. But I want you to realize up front that the reason why I ask for all this stuff now is so that I can do all the stuff that a potential buyer is going to do and will do during due diligence and the legal process. Because once the LOI is signed and the due diligence starts, I would much rather them call me and me ask them a question than go to me and I'm having to go ask a buyer or seller about what they have and what they don't have. It's embarrassing and it's clunky, and I don't like clunky. So I try to get all the information up front. And I will say this, being trained at a large system um truly helped me be able to see how every string is attached to every other string. And when you run a smaller facility, maybe 30 beds, even up to 100 beds, um, you may not be thinking about all the implications of that because you've got payroll to meet, you've got joint commission, you've got CARF, you've got, discharges, you've got all these things that you're worried about as a founder and a CEO that you've hired other people to work on and they're doing a fantastic job. But someone to come in and say, here's how everything fits together. And then if we pull one string or change one string, this is the implications that it has.
So I think that's great context. A lot of people who watch and listen are in this stage of their business, or either opening their or thinking about opening their own, and understanding that is I think is wildly important. But also, I mean, you bring up the term of hand holding. I think I know that's from very strong alpha people who run programs and who are very driven and persistent. They don't want their hands hold, but you need your hand held during this process. Like, it's not a bad thing. We're going to guide you through. We're going to walk together. And I think that's much more needed than I think a lot of people realize. Similarly, you brought up a cool topic of vanity KPIs. When I look at triaging from the growth Sherpa side of things, of the priorities of an organization, we have the vanity KPIs, we have the systemically important KPIs, and then we have the advanced metrics, right? You have the advanced analytics. My biggest focus early on is at least capturing data so you can have the basic KPIs down. So I don't think you can ever do that too early.
Right.
For all the programs where I get calls for a lot of people who are opening up in 3 or 4 months, and I'll say the same thing every single time. One, get that website built yesterday with strong content creation and strong SEO strategy, because the best time to plant a tree is 15 years ago. The
Mm-hmm.
second time best time to plant a tree is right now. And you missed 15 years ago with your website. So let's go right now. Let's start building out content and driving calls 3 months from now. That's the only way to do it. And the second thing is data collection right off the bat. Because even if you can't do much with it because you're so busy those first 3, 6, 9, 12 months,
You're so right.
you have it. You absolutely have it. You can go back and say, okay, let's see where we're getting our best KPIs. Where's our best cost per acquisition? Where's our worst close rate? Like, where can we get better? And instead of a year in, I can say unequivocally, it's harder to implement these structures a year into a program or 2 years into a program. Or in some of my clients, it's been 15, 18 years into their program. We're now putting in a CRM for 50 reps and all these locations. And that is cultural leadership change management. That's hard work, but when it's there from day one, at least starting the process, for me, that's the triage I look for. And that could be any size program. The second you open those doors, you have to be able to record calls, you have to be able to record the admissions process and the discharge process. And so I don't touch on EMRs too much. I think that obviously they have a valuable need, and there's a lot of them we like, but just for me, if I have that information on the front end as a consultant, as a partner with a business, there's so much more you can do. You can go further faster with that.
Very much so. And even when you're thinking of let's go back. I want to address the alpha thing for a second
Mhm.
and the hand holding. To all the alphas like me who are out there listening, I want to rephrase that and say, let me be your buffer. You know, I'm the one standing in front of you taking the little darts and arrows because I want you to be able to continue to run your business. And I'll turn to you and ask you for the information. So if that makes it more palatable, then so be it. But I'm there
Yes.
with you. Um, but talking about the data, you're right, gathering it in any way. And some people know they're supposed to do this, but they don't know why. And so I always like to, in any transaction or even in any pitch, when I'm talking to a company that might be interested or a buyer that says, "Hey, I'm interested in this space. I'm looking for X, Y, and Z." And we have several buyers that look for specific things, um, and have the proof of funds to do it, and which is great. And a lot of people don't have that, but also want to help maintain the culture, and I think it's very important. But I let them know that, there are certain metrics that you want to make sure that you're looking at and capturing. And we may have the data, but we just don't know what it means. And so for both buyers and for sellers, I always start with the happy ever after. It's like, this is why. Okay, this is what we're looking for. This is our goal. This is what we're wanting to implement or make happen or move forward. And then we start with the once upon a time, which is how we're going to do it. Now you've got, you know, legal pads full of numbers and, all that. You may have a Excel spreadsheet that has a bunch of numbers. You're like, well, I captured this, but I don't know what to do with it. I don't know what it means. And bringing in somebody to help decipher all that stuff is very important. So those numbers start to take a shape. There's a story behind every number and how you get there. And so in the M&A world, we call it, quality of earnings. Um, and that's looking at every dollar that goes out, every dollar that comes in, the return on investment for every call versus every admission versus every payer, how all that fits together. I'd rather do the quality of earnings, a simpler quality of earnings with the seller prior to even going into due diligence, because this is what you're going to be asked. And this is probably the first time for smaller companies that they've really dived in and started looking at things from a very holistic, but also very granular view. And it also helps to give them a nice reset, a level reset, because hey, I start a company and my census is good, I'm meeting budget, I'm making profit, I'm more than breaking even, and my business is worth 10x. Okay, that's a perceived value.
Right.
Well, what's the actual value? Because you may think it's worth 10x, but the market may think it's worth 3x. So there's got to be something there in the middle. And I let the buyers and sellers know as we're looking at these metrics that every single metric drives the value of that business. And we need to make sure that we're crossing every T and dotting every I beforehand. And I think that's just good business practice, regardless of whether you're buying or selling. Um, Always look for an exit. So that's when you're called in. That's when I'm called in. And I'm actually doing the exits, but you're called in because I want to make my business better. And yes, maybe 3 or 4 years from now, I want to be able to exit or, you know, do something different. And you're helping them get ready for that exit. I'm helping them get ready for maybe a closer exit. because they're at that point where they're ready. And where they should have called you in probably a few years ago, but now's a good time to start too. The whole tree analogy you just gave. And I think that's very important, that buyers and sellers both recognize that, oh yeah, we get 1,000 calls a day, you know, that's wonderful. Well, how many have convert, where they're coming from, who, those type of metrics are great if you know how to use them and if you're coding them correctly. If everything is coded as internet, it doesn't give me any, well, what internet? Your paid ads? Is it, you know, through an online service? Is it through click? Is it through organic search? Is it for all those different elements there? Where are those calls coming from? And then the business development. I think most mental health companies and even recovery centers, their largest referral source is former patient or walk-in. They had to get there for some reason, somehow, or hear about you somehow. Gone are the days of yellow pages, so they didn't find you in yellow pages, or they may have looked at you up on Google, but that needs to be entered in there. They're not just a walk-in. So training what data to capture and how to capture it up front, even if you're opening day one, is so important. And we've got folks that, hey, I'm looking to start a business, and I'll say, well, make sure you do these things. And that's just that's advice I'd give anybody that called me, and not charge them for that, because it's like, I want you to be successful. And if you've got the chutzpah to go and do this, more power to you, because the demand is not going down for behavioral health and SUD. Yeah.
So I love to bring up quality of earnings. I want to talk about that for a little bit because that's a topic that comes up a lot, and it always reminds me of a couple scenarios. So the first is was working with a client in past and reading through their KPIs. The numbers don't lie, and so we're looking at this process. And what I saw from my perspective was call volume goes up, admissions go down. Interesting. Conversion goes down as well. So what it told me was they were slightly understaffed and the admissions team, right? Whereas one more FTE would have actually kept that higher, it would have kept revenue higher, and it would have kept, you know, basically things moving forward. But that was the biggest red flag that I saw in that entire deal, because if you aren't staffing one person, which is causing this going on, and not keeping eyes on it, what else is going to be overly lean that's going to fall apart once the transaction comes to terms? And so for me, when I see things like that, that's where I want to coach my companies to say, hey, look, sure, you have to spend $75,000 more dollars a year on one, you know, admissions rep. Your average deal size is $30,000. They get 2 a month, you know, over the course of a year. Now you're talking about a 10x return on that one person's investment. Done. That's a no-brainer. That's simple math for any treatment center to use. Is for every dollar you spend, if you get $7 to $10 back, you're in a good place. And so the short-sightedness, I think, of going lean in some of these programs can cause these massive issues, which for me deteriorates the whole of the organization. I see that and I get afraid about what else we're cutting corners. Are therapists understaffed? Are the nurses understaffed? Has the facility not had repairs that needed to be, because they want this big margin there for that multiple, and that gets me scared when you see it on something so simple as, well, you need one more admissions rep for the course of the year.
Mhm.
And similarly, from quality of earnings, it's a concept that I wish I could shout from the mountains more from a consultancy role. That you're right. Like if you're in a new organization, you're paying your bills and you're getting a little bit of gross profit, you can reinvest and you can start doing these things. It feels good. But if it's all from other treatment centers referrals, or it's all from pay-per-click, or it's all from these singular buckets that can go away like that,
Mhm.
that to me is fear. I have fear when I see that, because I know that if Google changes an algorithm or a referral partner decides to go in network with that insurance that they're referring to you or get that same level of care, your entire revenue stream is gone. So I know here at Grocery Up and me personally for years, even prior to founding this, I've always been a big proponent of diversification and looking at the whole ecosystem of patient acquisition versus looking at just that top revenue in by department or top revenue in by total.
Mhm.
Um, I think from a short-term perspective, it can be a little more work for a treatment center to pivot off that strategy and do different activities in the field or on digitally. But long term, it's that one less headache you have a year from now.
That's
It's that
exactly
one less, yeah, it's one less argument you have with that referral partner who sent you three and you sent them five. It's like, what would you do? What are we doing here, guys? Let's create this and stop these squabbles. There's 30 million or so Americans or more who need medical necessity for our treatment programs.
right.
You and I talk about all the time. Let's not have 50 flavors of vanilla. Let's all be specific, be intentional, and create this diversified patient acquisition revenue generation plan. To me, I think that's really exciting for a program who can buy into it because it's a hard process to go through if you've never seen it. But when you're on the other side of it, I gotta tell you, from my experience, clients we've worked with who've gone from point A to point Z are ecstatic. They're happy. It's predictable. Usually, honestly, the biggest problem is staffing up therapists and admissions counselors because the call volume just blows up, and they start operating from a place of abundance and not fear. And I'm sure on the deal side, when you have someone who has an abundance of calls coming in, a diverse mix, they have revenue streams that can balance each other out if it's Christmas or if it's summer, like where it's coming. I think that's the type of deal that I try to get all my clients to, whether they want to sell one day or not. But even if they don't want to sell or they don't want investors, they can go to bed at night on a Friday, not freaked out what's going to happen if three people AMA on Sunday.
Hmm.
Um, that's, I think that's the difference between owning a business, and having the business own you.
That's exactly right. And it's interesting that you mentioned some of the trends in there. When I was overseeing hospitals and working with individual hospitals, their directors of business development, director of admissions, the CEO, the CFO, I would always remind them, don't forget, this year we've got spring break and summer break and fall break and Thanksgiving and Christmas and Hanukkah and New Year's and all those different holidays. And guess what? They happen every year. So let's prepare for them. And they do. But sometimes we forget those trends. And I think, believe me, you and I came from the same organization. You worked for one part, I worked for the other. So you know how big works. Well, I could put all my hospitals together and look at trend lines, including the SUD side from where you came. Those trend lines all are the same. Some are higher, some are lower, but the curve is about the same. Being on this side and seeing the flow of traffic going one way and the oncoming traffic coming another way, and being able to navigate that traffic, I see a larger data set and the trends are exactly the same. So every treatment center is facing the same trends. The market just kind of shifts like that, and it's very interesting to watch. And people a lot smarter than me have tried to figure out why. And I don't think we'll ever get the real reason why, but we just know that it follows the trends. And, any anomaly is going to be just that, an anomaly, and we'll just move forward. So just a general overview, a quality of earnings. I actually had a client describe it to me like this. It's like the FBI raiding your home and going through everything. It is a very thorough audit. It goes beyond an audit. An audit usually just looks at financials. A quality of earning looks at every dollar coming in and every dollar going out and the reason and story behind it. So yes, where is your income coming from? Are you putting all your referral eggs in one basket? If 100% of your referrals are coming from, um, internet marketing, is that a risk? As if 100% of your referrals are coming from the emergency room, and I'm gonna stop right there and say about emergency rooms. The organization from which I came, the assumption was that 60% of all of our admissions came from hospital emergency rooms. Well, COVID hits and yay me, I'm put in charge of the data dashboard project. So looking at everything from an enterprise level at a KPI standpoint, not a financial standpoint. And the data proved over and over, because I kept having that statistic in my brain. It's like, it's not 70%. It's not 70%. It may be in some individual facilities, but overall, emergency room admissions were around 30, 35%. The rest was business development driven and marketing driven. And I had people arguing with me. It's like, no, it's 70%. I'm saying, well, the data says, where did you get your data? Directly from the facilities. And we had double checked it because I wanted to make sure. But if you have 70% of your admissions coming from one location, that's a huge risk because if 70% of your admissions are coming there, guess what? The competitor down the street, 70% of their admissions are coming from the same place. So everybody's going to go where the biggest buffet is going to be. So quality of earnings absolutely looks at where is your business coming from and what are the risks associated with that business. The second thing is your payer. If your largest payer is the VA, you've got to be aware of all the policies and procedures and all the things that are going on happening with the VA and Tri-West and the Community Care Network. You've got to be aware of all that stuff because right now some people are able to build a percent of charges. Other people think that, oh no, that's going to change and we're going to have to follow the VA fee schedule. Well, no one knows. So you have to be aware of that. So that's a risk there too, of putting all your payer eggs in one basket. A diversified payer mix is very good. When I headed up the payer mix optimization program at my last company, which was a huge enterprise-wide endeavor, we started off with a few facilities. First question I asked, who's your largest payer? Medicare or Medicaid? I said, okay, they're your biggest payer. Yes. Well, rate-wise, they're not, but volume-wise and utilization-wise, they are. Now, what would happen if you lowered that and raised it up with some of these higher payers? Because you're actually making room for folks. Is that a risk for a greater reward? So if you're putting all your payer eggs in one basket, again, Medicare, Medicaid, TRICARE, VA, Blue Cross Blue Shield, which is usually the largest payer in every state, putting all those eggs in one basket, that's a risk because we know payers have a lot of power, especially when everybody's still trying to figure out value-based care. And side note on that, we as behavioral health and substance use treatment professionals need to be leading that conversation and not relying on insurance companies to try to figure it out for us. We know what our outcomes are. We know what good treatment looks like. We know how to reduce recidivism. We know how to create long-term integration back into society where people are following their program and getting the help that they need. In fact, if you look at most major markets where there is a large inpatient psychiatric facility, around them are several mental health professionals that have started their practices to not only feed, but feed from those discharges. So a network has already been built for a lot of these places, and we can be that network. Your facility can be that network. The other quality of earnings is, okay, who's on the payroll? Almost looking at every single position, what they're paid, what they do, all those things. Is this a position that we really need? And it sounds cruel, but we're just looking at paper. But we need to have the seller make a compelling story for every dollar that's spent, every position. Why are we using this particular pharmacy? Why are we using this particular outside internal medicine group? Why are we using this mobile x-ray company versus this? Why are we doing our labs off-site when we could probably do cheaper? And answering all those whys, whats, and how can we do it better? And quality of earnings are painful because you're afraid that you say the wrong answer. It's like, well, we failed the test. It's not a pass fail. They're looking at things to making sure that if I buy your business, that I'm going to have the same success growing it like you did, because I'm bringing more resources to the table. I need to recoup my investment or my multiple of your EBITDA or your net earnings or your revenue. I need to be able to increase that. So I'm just making sure that everything that you're saying, I'm not surprised when you hand me the keys. So you didn't tell me that the gas tank had a leak. It's like a full disclosure type thing. And it goes through everything. And so we like to do that with our clients up front, to some degree, to say this is what you're going to be asked. And again, I go back to the marriage analogy. Is like, the questions that a father should ask, his daughter's fiance. It's like, what are you here? What are your plans? All these things. And I think it's just a matter of being open and honest. And a lot of times the right answer is, I don't know. And that's when they pick up the phone and call someone like me or someone like you and say, I was asked this question. What do I do? And then we walk through it, just
Yeah,
like a good therapist would.
exactly. I would love one of those conversations. I find that fun is to work with treatment center owners to go back and do the forensic deep dive into where the revenue came from and where the best and worst things of it are. I love that.
Mm-hmm.
Probably an interesting thing about payer source. I think it's probably the most controversial thing that I tend to say about policies for the commercial payers. I'm not going to jump into government funded TRICARE or Medicaid Medicare. It's a different world. But for a commercial treatment center, I get asked a lot, can you get me more of this policy? This policy pays us well. I want more of this prefix. I want more of this policy. And my general response is I don't care about the policies or the prefixes. I want to bring good quality people to your door and give them the opportunity to go to treatment to your center. So whether that is through ideal patient targeting, through creating patient profiles and personas and doing your front end marketing on that, or doing outcomes based marketing, which we're really excited about here at Grow Sherpa, of finding out who does your treatment center actually treat best, who gets the best outcomes, and then reverse engineering the marketing practices and outreach practices to find more of that person. Then hopefully you have long lengths of stay, less AMAs, better outcomes.
Mm-hmm.
It's a whole cycle. Because in my opinion, I think if you focus solely on the policies, sure, you can get more money per day by the people you bring in, but you're negating those interwoven spaghettis of, will that cause a milieu mismatch? Will it be a shorter length of stay? Sure, it's more money per day, but they're out the door in 15 days because they weren't a great fit for the program, and now you have to replace that person, whereas someone else could have been there for 30, 45, 60, remain sober for 60 days, 90 days, a year, and now is an advocate for your program. So I think it's short-sighted for a lot of programs to work with to just go for policies versus going for people. And, you know, hopefully you don't mind me sharing. Obviously, as a person in long-term recovery, you know that the people person of what we do is, in my opinion, the second wing on the plane between the business acumen, right? So,
Mm-hmm.
so yeah, for me, finding the right person is way more important than finding the right policy. But if you find the right people, the right policies follow. So that's always been my controversial stance for programs I work with. And
I
it,
don't think it's controversial at all.
you haven't been on all the phone calls I
Well,
have.
um,
But no, I mean, it's fair, right? You see the dollar per day, and as a business owner, it makes logical sense, right? But it's taking that trust fall into putting your program's culture and treatments just a hair ahead of that revenue per day number, which is looming when you have to make payroll and budget and rent and all that. So I get it, but I think it's backing into the solution from a different perspective.
well, you're basically talking about old school marketing, okay? And I'm older than most people here on your audience, I'm sure. But if I had the tools today when I was first starting out in marketing, and we're talking true marketing, product management, at a manufacturing company, where everything was pretty much manual, I would have loved it, and I first started doing business development before business development was a thing. I didn't know, no one knew what business development was. And so what you're saying is not putting all your eggs in one basket. I think that's common sense. But I also think that, yeah, when you look at net revenue per patient day, yeah, we want more of this payer, we want more of that payer. That is human nature, because if we have more of that payer, it's going to allow us to treat more people. But we have to weigh the risks and rewards of that. It's like, well, are going to be denied days? What's the copay? Those type of things. So we have to look at all the financials around that. Um, and I think going back and doing the patient profiles, now you're talking business development. now you're talking feet on the street. And when I started in behavioral health, we didn't have a real corporate marketing department that focused on the behavioral health side of things. So the individual directors of business development at each location were the marketing department, the sales manager, the copywriter, the webmaster, all the ad agency, the creative department, all that stuff. And then negotiating payer rates on top of that, which was my favorite job. But we saw all those pieces, and then making sure that the sales reps were calling on the right people, and then talking to the right referral sources. And this is before, the pay-per-click and the social media, because we both work for a very conservative company. And it was difficult at times, but it was also made us very creative, and we were very good at what we did, and we were good at B2B um, business development. And now I'm a firm believer most of it's B2C, because consumers still have a choice in where they get health care. They still have that. They don't have to go where their doctor tells them to go. So with that said, developing those profiles of patients, it could be a composite, or it could be a child, an adolescent, a young adult. It could be a persistently mentally ill patient. It could be a geriatric patient. Developing a profile of that and knowing who to go to that treats those type of patients. The same is true as now you're taking it and making it electronic. What groups do I need to go, and what are all the algorithms, and what are all the process flows and the workflows that I need to create to make sure I'm targeting the right people, is the same thing that you do in sales, is making sure you're targeting the right companies. Now, I can walk into a physician's office or a mental health professional's office or an interventionist office and say, hey, I'd like you to send me all of your patients who have payer X. They may or may not, but they're going to send me what they have, because they may see patients who have more of Y than X. And so I can't control what they refer to me. My goal is, please refer to me, and please refer. And here's our criteria, and here's what we can treat. I remember having a conversation with a medical director one time. It's like, we would like to stop getting patients with this insurance because of the things that we have to jump through as physicians. I said, I would love to be able to say I've got that under control. But I looked at the referral sources that were sending that. I said, but these folks are sending maybe one or two patients with that insurance, but they're sending a lot more with the commercial insurance, with Medicare, those type of things. So I can't control what they send us. All I can control is, here's who we take, here's the best programs for these types of patients. Please use us, and ask for the sale. And they understood that. But it's a hard conversation to have when um, people have that, they're looking at one payer rather than looking at the optimization of the entire mix. Yeah, if I target a referral source that has primarily this commercial insurance, chances are that commercial insurance is going to go up. And then you work very close. And here's another thing. Business development always needs to, and marketing, those three together, always need to know what's going on with each other. Admissions needs to know, hey, we're going out and we're doing a blitz on these type of folks. So expect an increase in call, and here's our message. Marketing needs to tell business development, hey, we're doing a campaign on X, Y, and Z. Wanted to let you know. And by the way, admissions, you may start seeing an increase in this because of this campaign. There are still silos even in small companies. So that goes back to the quality of earnings, but it also goes back to, how do we improve our business, and how do we treat the patients well? There are two things that I think if you asked any family member or any patient or potential patient or former patients, especially parents that have children or adolescents that need inpatient treatment, for mental health or even substance use. I'm going to ask two questions. Will my child or my loved one get better? We know in some cases they're not going to get well or cured. It's a long-term thing. But are they going to get better? Are they going to be able to get to the next stage where they can go into the next, or stabilize to get to the next round of treatment or the next level of care? And the second thing I think is so important, will my loved one or my child be safe? If you can answer those two questions and do those things, you own the market. You own the market. Just do what you say you're going to do. I don't care if you're vanilla bean ice cream or French vanilla ice cream or country vanilla, whatever. So many flavors, but just do what you say you're going to do. And I think that's so, so, so critical.
Agree. You brought up a couple interesting topics. I like the concept you said of basically finding a way to say yes. You have one or two problem payers or one or two problem things coming from a generally otherwise great opportunity, right?
Mhm.
It reminds me years ago when I was in the field, I had a small rural hospital ask me if we could pick up patients for our nearest treatment center, which is like 3 hours away.
Mhm.
And it'd be very easy for me to say no. But I asked that one follow-up question of how often does that happen? I said, maybe once a year. Called the CEO up. Can we pick up a person once a year from this hospital if it means we're getting 3 admissions a month from them regularly? I said, absolutely. We're definitely going to pick up one person a year for $1 million a year account. That's not an issue, right? But how many treatment or how many BD reps in the field would have just stopped at that and said, sorry, our policy is not to pick it up? They keep finding that way to say no. So I love any story of finding a way to say yes. I think, especially for our vulnerable patient profiles, showing them yeses versus nos is just
Mhm.
so paramount. And the other thing you brought up has got me thinking. I think it's funny the progression of the business development profession and as a whole. I had a boss back in my late 20s who was selling way before me. I say, hey, how was it when you would sell in the field back in like the early '80s? He goes, well, we drive into a town the night before and you go to your hotel and you pull out this map and you put 3 pins on it because you have your 3 meetings for the day and you follow your map around this town and you meet with your people and then at the end of the day you put a dime in a payphone and you'd call your orders in and that's your day. And then I started in the field where I had my external GPS on my dash. I had my 4 or 5 meetings to plug in, so I was a little more efficient, a little faster. I had my BlackBerry with my first CRM ever. I think it was a Citrix CRM. And I'd have to go back to the office at least once a week to plug my BlackBerry into a dock to upload my reports. And then I would say that progressing to the last time I was in the field where it was, you know, Salesforce on the smartphone, in-dash GPS, 5 meetings a day, texting all day, calling all day, emailing all day. And to now it's social media all day on top of all of that. So you're right. I mean, I still think there's a very, very strong B2B presence, but now because of the way you communicate, B2C really is the scaffolding that holds the B2B together for patient
Mhm.
acquisition and addiction treatment. And the BD person's role has now expanded from even back in not in it doesn't feel like so long ago for me. For younger folks who watch this, it looks like a long time ago for me, back when I had brown hair and no glasses. But it really it's transcended efficiency to basically a decision-making process of what won't I do today? Because there's so many different ways you can talk and communicate with the client, the referral source, the patients, the like there's just so much communication opportunity. What do you prioritize? I think
Mhm.
that's one of those things that maybe more conservative hospital systems might not be thinking about or moving towards yet because it's hard to move those big ships.
Mhm.
But that's the competitive advantage a lot of smaller programs can be is if they hit that, we talked earlier about that triage point of saying, when do I make certain pivots? In business development strategy, you could be at a time to make that pivot to say, how do we take invested intentional time to work with our reps to utilize technology and contacts the best way possible? And that I think, I mean, that's obviously a very long discussion, but I think it's one of those things where having at least that thought process and intention of doing it can really make that that program stand out in the community and be more effective.
Mhm.
Just that little move to intentionality of business development contact points.
You brought up something that made me think of this, and I've said this to my facilities, and I've said this to potential clients and even, potential buyers. Um, the best salespeople in your organization are your admissions team. They've got to
Yeah.
close the deal. Okay. The best marketing people are the clinical services team because they're creating the products and services. And marketing is really now a large, very data-driven public relations, getting the message out, getting the good stories out. And then business development is making sure that we're on the streets, we're talking to the right people. And I think from a business development standpoint, I've run into this when, at some of the hospitals that I oversaw. I'd have a VP ask me, well, I think we need to hire another business development rep here. So that would be wonderful. That would be great. It would expand our footprint, but I'd rather use that FTE in admissions because right now we're getting so many calls and we're creating this funnel and the funnel's getting clogged. And let's get that fixed. And then we'll hire another business development rep because the reps that we've got are doing a very bang up job. I think we also need to make sure that, and this is a pet peeve of mine. Business development is more than just dropping off brochures and donuts and pizza. Yeah, we do that. That's fun. I mean, I remember when I had reps that were on vacation, um, or even DBDs at a facility that were going to be out for a while. I was the acting DBD. I'd fly to a facility and sit at their desk for a week or so. But for reps that were on vacation, especially during the summertime, we'd all pitch in and take shifts. And I remember spending many, many weekends driving around to ERs, dropping off pizza and those type of things, just to let them know we were there for a holiday weekend and we appreciate you. Those things are important. But to every business development rep that walks into a door of a physician's office, a mental health professional, and I can't say enough about scheduled calls. And sometimes those are impossible or near impossible, but I think it's very important as you develop those relationships. They know why you're there. They know that you're going to ask for referrals. It's nothing shameful. And to be honest, they've probably got patients they need to send somewhere. And why not send them to you rather than the competitor down the street who actually comes in and talks to them and asks for the referral? And talk about your program and be knowledgeable about your program and be able to communicate the types of patients that you treat. And the data is in there. Usually those EHRs show a presenting diagnoses. And that's just as important on the front end in patient acquisition as it is on the back end with patient retention. And we can talk about discharges as part of the business development process too. You know that. But engaging the patient before they leave with folks that have good reputations in the community, whether outpatient, IOP, a step down, whatever it is, but creating that stickiness to where if I need treatment again, I'm not going to go where if I have to show up at an ER or I'm in a crisis or something like that, and I'm not going to go where they just send me. It's like, no, I'm going back to, Steve's hospital. I'm going back there. And there's so many ways to create stickiness. I'm working with a company right now that has created an app that wasn't even created for this industry. But working with them on saying a few tweaks and this would be perfect. They click a button and their circle knows, including their discharge planner or their peer support specialist, and that's a whole nother topic we could go into. And then their sponsor or whomever in their circle that knows that, hey, I hit the green button, I'm safe. I went to my meeting, or I hit a red button, I'm like, I'm having a really tough time. Please, somebody reach out. And it's great for alumni. It's great for those things. And so this product is incredible. It's simple and it's ready to go. It's just there's so many things that we can do to create stickiness on the back end, but also create stickiness on the front end to where if a referral source picks up the phone, calls you and hangs up the phone and said, I know it's taken care of. I don't have to worry about it because Steve's going to get transportation to come pick up this patient. They're going to make sure they arrive safely. They're going to get them to the appropriate level of care for their condition. And then they're going to communicate with me about the state of the patient so that when that patient is discharged, and they're going to discharge them back to me rather than somebody else. There's this whole throughput that everything works together. And so part of that quality of earnings, let's go back to that, is that patient journey.
Excellent. Since we're running short on time, I do want to ask you one more question. Make sure we got in there. And for anyone, this is actually what Tony and I do talk about at conferences whenever we're sitting here at dinner on a patio. This is actually the conversation. So I dig the way this has went. So since you've been working with Blue Star and you've been out and you've been able to see both sides of the road, is there any one thing that you reflect on? You say it stood out the most that you'd want to share with people who are in this field, whether it's, from the business development side of things or corporate ownership or program ownership? What's one nugget you can leave everyone with? That's something that you've seen since leaving, working with big organizations, hospital systems.
We all talk about strategic plans. We all talk about, oh, what we're going to do this year. I've got clients that have, they're still working on their budget for 2025. Well, they know they're going to do this, but they don't have a pro forma. They don't have a plan. They're working on their plan. And we're helping them work on their plan. But I cannot put enough emphasis on having a plan, a strategic plan. Now, your strategies may not change. How you get there may change. Okay. But let's bring that down to a couple of notches down to I'm ready to sell. Tony, I need you to put together a prospectus or a pitch deck. And we need to send this out to some prospective buyers. The one thing I insist on all the time is a development plan. If you were not to sell the business, what are your plans for growth? What are your plans for expansion? What are your plans to maybe go into new markets, new programs, new services, new levels of care, all those things? And it's like, well, we just want to sell. No, you need to. I've seen deals be turned away because, well, these folks don't have a development plan. I was paid to actually help one company put together a development plan to go into their pitch deck. And when I saw the pitch deck, it wasn't included. And I was like, oh, okay, I got paid, but I was still kind of hurt because I thought it was a pretty good development plan that we had developed together. So the one thing that I would say, regardless of whether you're at a point where you're ready to sell, always have a development plan, not an exit strategy, a development plan. Because with what we have now, whether we bootstrap it or whether we go out and get additional financing or we find a partner, here's what we need to do to grow. Here's what we want to do to grow. And that could include getting in network with these payers or, decreasing our reliance on, emergency rooms. And then how are we going to do that? So really thinking it through. And that's where people like you and me and others come into play. And just for the record, Steve and I are not competitors. We're actually, cooperators.
Right.
So that's where people like us come in and say, okay, well, why? And then from the buyer side, I'll tell them the same thing. Look for a development plan. Look for a development plan. If I'm representing the seller, I work for the seller. It's my company. I'm selling my company, and I want to make sure that I get the best price. But it's proxy for the owners. If I'm working for the buyer, I'm trying to get the best deal. I'm trying to find the right company, the right fit, because I'm the one writing the check. And I'm the one that says, well, how will this fit with what I currently have? Do they have a vision? Do they have a plan? I can work around some other stuff, and fix some things, maybe bring in this type of EHR, maybe do this, maybe do this. But at the core level, is this something that a business that's got it and they know what they're doing, but if they chose not to sell, they would just continue to thrive. And I think that's important. So I can't say enough about corporate development and what the next steps are, because in this industry, you see larger companies still in acquisition mode, de novo mode. You have mid-level companies that are in acquisition mode, de novo mode, and you've got smaller to medium-sized companies that are looking to expand and grow, exit, or even find someone to acquire themselves. So that's because it's not that there's so too many treatment centers or not enough treatment centers. It's because there's so much demand for the services that there aren't enough to go around. So if you have a treatment center that's 30 beds and you're only running 10 or 15, it's like, it's not because there's not a market for it. So,
Exactly. And I would say, just to add to that before we close, not even just for the executive side of things, all the way down. If you're a business development rep, marketer, DBD, missions counselor, and your organization doesn't say put out an annual strategic plan, give yourself an annual strategic plan. Check yourself monthly, quarterly. That's how you can ensure progression. And like you said, it might not stay the course. You might have to pivot. You might have to make some adjustments. But it's, aim small, miss small. You'll be a lot more likely to hit and achieve your goals at any level of organization. And even if your organization gives you goals, like my whole sales career in the field, I was always given the target of X to sell. I never cared about that. I wanted to be doing twice the amount of revenue as the number 2 person in the company. That was my target every year. And that was the strategic plan that I did. And sometimes I hit it. Sometimes I didn't, but I was still doing quite well because that was the way I wanted to approach the business. So I think that's one of the things that from top to bottom, absolutely is a must. And I like it even better in the perspective of, if you think you're going to sell, still do it, because it might not, and you'll still have a business to run and people to care for, and you should be doing that. So Tony, I appreciate you today. I know we can keep going. Can you tell everyone where to find you?
You can go to our website at www.bluestar360.io. That's .io. Or I'm on LinkedIn under Anthony Porter, and you'll see my ugly mug in my profile picture. But again, it's Blue Star, all one word, 360.io.
Excellent. Appreciate you having on. And if you have watched this far, thank you. That's
Thank you.
awesome. I appreciate that. Subscribe, like, comment, all those cool things, and feel free to share to everyone you know. Appreciate you.
Thanks, Steve.
That's a wrap for this episode of The Lead Climb. We hope you picked up some valuable insights to help optimize your patient acquisition and grow your behavioral health organization. If you found today's discussion helpful, be sure to subscribe, leave a review, and share this podcast with your network. And if you're looking for expert guidance in digital marketing, admissions, business development, or any other piece of the patient acquisition puzzle, Growth Sherpa Consulting is here to help. Visit us at www.growthsherpaconsulting.com. Thanks for tuning in. We'll see you next time on The Lead Climb.